Okay. So what I was talking about is there is एक तो आपने बात सही की खोलते हैं, you can see not ooze, but you're seeing a spurt. It means it is a little vessel has a little more diameter than that. There is another scenario also. For example, your patient is in a post-operative room, or you have closed the skin. And after closing the skin, you see the drain bottles, which is a normal. And you see this thing under your eyes, the draining bottle is filling. Usually the drain bottle does not fill in front of your eyes. It takes a lot of time for it to fill 5, 10, whatever millimeter it's going to correct, or 20, 25, whatever it is. But if it is in front of your eyes, it is rising. A patient is in post-operative care, not gone to the ward, there it is rising, then it means it's a major vessel which is bleeding. And when I talk about major vessel, I'm talking about the vessel which is supplying the thyroid, or draining, which is the superior thyroid or inferior thyroid artery, or they are usually, then a ligature has slipped on them.
Sir.
And what you're going to do?
Reactionary hemorrhage, sir, most probably. And we will shift the patient to the OT, remove the stitches, and identify the bleeder and secure the bleeder, sir.
So that has to be kept in mind. So this is what is bleeding, in fact. Now the problem is that, let us say next day you are picking around. There's another problem also. Let me deal with that first. Let's finish the breathing problem. Another breathing problem is not this. Another breathing problem is that the anesthetist remove the tube, and patient can't breathe properly. Previously, we were talking about tube has been removed, patient was breathing normally, has gone into the ward, and then he has started developing breathing problem. Now, this problem is on the OT table. So what is the cause?
Sir, most probably this is long-standing huge goiter that has caused tracheomalacia, and that is probably the main cause of this respiratory distress.
Now, that is very rare. What could be more common than that? Why somebody has a breathing problem as soon as you have removed the... आपने वो बात सही किया, that is one cause, but that is not the commonest. I think I'm unable to understand, to communicate the question. Let me rephrase it. So immediately...
So nerve injury?
Nerve injury. Which nerve?
So recurrent region.
Okay. And what do you think? That recurrent nerve has been cut? Or not?
Yes, sir. Unilaterally damaged is more serious problem.
Well,
bilateral.
Bilateral. Well, there is to understand this thing, you have to understand the nerve supply of the vocal fold, which has the muscles in it. Vocal fold. The problem is that it is unique nerve, recurrent laryngeal nerve, which has both fibers in it. Those which abduct the vocal cord and those which adduct the vocal cord. Abduct means opening, adduct means closing. Like in thumb, abduction, adduction. Adduction closing, and abduction is going away. So therefore, since it has both nerve fibers, so therefore, if a nerve is cut, then both abduction and adduction fibers, they will be cut. And once they would be cut, then the vocal folds are not going to lie in the midline. Neither they are going to lie like this, open, totally open, neither in midline, somewhat in the middle, like this.
Cadaveric.
Cadaveric position. So since it is in this position like this, there is space present. A patient is not going to choke. So therefore, if someone is damaging the nerve, as far as the patient is concerned, cutting the nerve is going to cause less respiratory problem. Obviously, ये तो आपने बात की, both sides involved is going to give you more problem. Now, problem is this is somehow or the other, those nerve fibers in recurrent nerve, which are responsible for abduction, they are damaged earlier if the nerve is not cut. For example, let us say the nerve is not cut, but your one is not gentle in handling over there, and the nerve has been stretched or the nerve has been traumatized because of the manual stretch, or you are using diathermy which is near it, and because of heat it is damaged and not cut. Then abductor muscles, abductor nerve fibers, they're much more sensitive as compared to those nerve fibers which tend to adduct the cord. So therefore, if patient is not breathing, he's choking himself, then there's partial damage to the nerves bilaterally, usually, and that resulted in loss of abduction function, and since there will be loss of abduction function, it will adduct. So that is how it is going to cause it. Let me narrate you. The sensory nerve supply to the larynx above the vocal fold is from spherolaryngeal nerve. We are not trusted in that. The motor nerve supply to the larynx is from recurrent nerve, which is a branch of vagus nerve and which supplies all intrinsic muscles. Only one of these intrinsic muscles, the posterior cricoarytenoid, abducts the vocal cords during respiration. All other intrinsic muscles adduct the cord. As all the intrinsic muscles of the larynx are supplied by recurrent nerve, damage to nasus nerve or to vagus nerve will cause paralysis of vocal fold on the side of the damage. And obviously, when that will be paralyzed, all muscle will be paralyzed. It will be the cadaveric position, as you were mentioning. So what to do now? अब क्या करेंगे? Yes, anyone?
We will keep the patient on ETT, like intubated.
Very good.
Re-intubate.
So you have to keep the patient on ETT, and obviously you're going to re-intubate. आपने कर दिया उसको, ठीक हो गया. How much time?
After 24 hours, we will recheck. We will try to extubate the patient. If the patient is not able to get extubated or start breathing, then we will do tracheostomy. If the patient is not able to like breathe on its own.
Okay.
3 to 5 days, sir.
The question which I'm coming now is, Atka, the tubes which we have now, endotracheal tubes, for how much time patient can tolerate it easily? Because the problem with endotracheal tube is long placement is, it can cause ischemia, which later can result in fibrosis and stenosis of trachea.
Sir, 7 to 10 days, sir.
Maximum 7 days.
So 7 is a very good figure to tell. आपकी बात सही है. To start with this, because you can check it on second day or first day and day, what is the status, and if it is still there, then obviously you have to keep in the tube. But if you have to keep it more than 7 days, then formal airway by means of a tracheostomy is to be done. Okay. Now, you have done tracheostomy. What are you going to do?
Like the tracheostomy care, standard tracheostomy care, like suctioning and keeping the environment humid, oxygen, etc. All these things, and keeping the like taking care of that tracheostomy tube in surrounding area as well. We will consult the patient regarding the tracheostomy care. Along with that, about the recurrent laryngeal nerve, we will ask the patient that maybe it's neuropyrexia and the patient may regain its the neural function after about a few months. Like we can examine the patient after re-examine the patient after 6 months, 12 months, and after and some says that we can wait till 18 months even for the neural function to regain, but maximum is 8 to 12 months.
Very good, very nice. And if it doesn't recover in that much time, what to do then?
So then we have surgical options for thyroidectomy. These options are there, and the Teflon injections.
Very good. So you have
To keep
mhm.
to keep the tubes like in the position where the patient can breathe, like vocal cords.
Very true. It's a very good answer which you are giving. What's your good name?
Saima, Dr. Saima.
Oh, Dr. Simon. It's a good answer. So this is how you are going to proceed if there is a damage to the recurrent laryngeal nerve. Now, my question is this. This is a case in the recurrent laryngeal nerve. You have found out it has been damaged once you have. But what about if during operation you discover you've accidentally cut the recurrent laryngeal nerve? Then what are you going to do?
Repair it, sir.
Repair it. Very simple. One has to repair it. And obviously, for repairing, you need a thread which is very fine. And possibly, if you have a facility of your plastic surgeons or someone, then it will be a good idea to get help of them so that they can bring their binoculars and
Microsurgical techniques, sir.
microsurgical
So
technique.
perineum is to be like sutured.
Very true. Perineum is to be sutured and that. So you have a fairly good idea about these things. Lovely. Now what I was talking about is, my patient has developed tingling. Second day you're taking around and the patient says, okay, I'm feeling a little odd and pins and needle sensations are there on my lips or on my fingers. So what is happening?
They're
This is
most probably damage to
hypocalcemia.
parathyroid
Hypocalcemia.
glands that has caused to hypocalcemia, sir.
Okay. Now, let me talk to one. So let it be Simon on this, and Fahd, we come to you in the second one after this.
Sir.
Okay, sir.
People can hear, so that's why it's easier one to talk. So you're suspecting it's a parathyroid injury. Okay. So what you're going to do?
Sir, I'm suspecting that it is hypocalcemia. So I'll immediately give the patient, like, do the calcium levels, serum calcium levels, and I'll start the patient. If the patient is having tingling sensation, then I'll start the patient on calcium, oral calcium. It is yes, oral calcium. Or I can give, if the level is too low, then I can give IV calcium gluconate as well.
And how did you know the level is too low?
If it is less than 8
But how will you know that?
milligrams per deciliters.
That is true, but I am talking about clinically. How
Okay, if there is perineural, so if the patient is having perioral tingling sensation, then it means that it is low. So I should give patient with IV calcium gluconate.
And how much?
And Schwastic sign can also be done. Sir, 10 milligrams of 10 ml calcium gluconate is given over 10 minutes, and 10 ml or 100 ml of normal saline.
Well, what you have told is correct. Now, let me translate it into, let us say, in a sequence. If you are in a ward, but there are two ways which can happen. One is a very obvious serum calcium level is low, is very low. And in that form, the patient is going to get something, signs of tetany. That would be there. One presentation could be that also. But the more common presentation is that patient has sensations of tingling and these, and usually patient says is there are mild sensations and these things are there. That is not an emergency. If it is not an emergency, then clinically you should do the examination and the test which you have told, that should be done. That could be tapping on a nerve, and tingling sensation on the face. If you tap with your fingers, then muscles can twitch, or you can apply a siphonometer and inflate the cuff, and the hand will go assume tetany posture. That is going to confirm clinically also. You can do that. And then obviously you have to give calcium. Important thing is, if you are giving IV calcium, then first take the blood sample.
Yes.
Because if you give a calcium, then blood sample after that won't be presented. And it doesn't take much time to take blood, because when you put in an IV cannula from the or the needle you have pierced into it, you have just to take out and then put in another syringe having calcium gluconate, and calcium gluconate is then given at a very low.
Okay. Yes, sir.
And once patient is stabilized, I mean to say, you see this thing, if they're mild symptoms, then it is a stabilized patient. So you can give oral calcium, start oral calcium, vitamin D, and patient is going to be okay. But oral calcium is important. If patient
Yes,
is
sir.
on IV, then IV calcium gluconate is to be given 8 hourly. But once clinically
sir.
you see this thing, okay, calcium gluconate requirement is becoming less, or you don't require that, then you will call the patient stabilized, and then you will switch over to the oral calcium medicines.
Okay, sir.
Or is the treatment of tingling sensation in numbness. Now, what there's a very, I'm talking to you. Fawad, ye bataiye mujhe, what is the complication of thyrotoxicosis which you dread? Operating on a patient of who has thyrotoxics, who is a toxic, which complication is which you dread and which can be fatal?
Sir, thyroid storms.
Thyroid storm or thyrotoxic crisis. And
Hmm.
that is the reason why it is so important to make the patient euthyroid before operation and confirm it is euthyroid. So what is the treatment of thyrotoxic crisis?
Sir, we will give IV normal saline, sir, oxygen support, and tablet enroll, sir.
Antipyretics,
Beta blockers.
paracetamol.
Diuretics, sir, mannitol.
Antipyretics.
And
Antipyretics,
antipyretics, of course.
Thyroid drug, IV
Antithyroid.
Inderol, Lugol's iodine.
Mhm. What drugs you people have told, that is correct. But the things to remember are, you see, it's a storm, it's a crisis. What is happening is that the whole body is flooded with thyroid hormones. It's flooded with thyroid hormones. It is in fact as if you have put the metabolism on a maximum level, and the metabolism is so high that everything is burning. Literally, if I'm talking about shairana tarike se baat karu, there's a lot of loss of fluid, so you have normal saline. There's going to be hyperpyrexia, so you have to control the fever. And the most important system, which is thyroxine, is going to affect your cardiovascular system. So your heart is going to be way back. It is going to be tachycardias and arrhythmias. And so therefore, you have to give medications to control the side effects. In fact, in thyrotoxic crisis, there are two arms, and the most important arm is the effects of the thyroid hormones, they are to be controlled. Plus, the thyroid, which can be produced more in the body, that has to be stopped by anti-thyroid drugs. But you cannot do anything about the thyroid hormones, which are already present in the blood till the lifetime goes away. This is the concept. So therefore, because a patient is sweating, there's a sympathetic nervous system which is being stimulated, and parasympathetic, their sympathetic is going highway. You have to give normal saline IV to control temperature. Temperature won't be controlled. You have to give injection. An injection would be injection paracetamol 500 milligrams. So you should know which injection you're going to give, IM or another one. And obviously the cold sponging, if it is a high grade fever, then you should have in your place a cardiac medications. If there's a tachycardia, then you have to give IV to control tachycardia. To control the arrhythmias, you have to have medications. And in antithyroid, neomercazole 5 milligram tablet, you have to start immediately. And obviously, there's tachycardia, so that IV Indrol denge, about 1 milligram IV Indrol, that is given. It's a continuous ITC monitoring. Things are changing in front of you, and according to that, you're titrating your doses and you're giving your medications and hoping for the best. This is how you're going to treat the thyrotoxic crisis. Now,
Sir,
thyrotoxic crisis, basically in thyrotoxic crisis, when somebody occurs, so if you have this broad knowledge, that is more than sufficient, because it comes under domains of intensivist now.
sir, I have one question, please.
G, please. By the way, when the time is running out, so when it will stop on its own, it means we have ended. G. G, please.
Sir, we are doing all these supportive measures, anti-thyroid measures, and supporting the systemic, and the patient is still in thyroid storm, sir. So, is there any role of dialysis in thyrotoxicosis, sir? To remove the circulating T3, T4, sir?
Oh, well, I think there is a role, because, and this is in line with the normal principle that plasmapheresis, that you exchange the plasma or you do dialysis, what you're saying, it has a role, provided everything else has been exhausted and you're losing the patient.
Because if we take the normal thyroid half-life, it takes about 20 days to normalize the normal thyroid levels in the body, sir, because of such a long half-life, sir.
So that is true. There is a role, because it also depends upon how much thyroid is in the body. Sometimes giving these things, they control the patient, and then after that you have to switch to oral medications also. वो बात आपकी सही है, that has a role. But let me talk to my internist, because tell you very frankly, in my life, I have never seen a case of thyrotoxic crisis. So I do not have first-hand knowledge how to treat a case of thyrotoxic. It's all bookish knowledge, which I'm telling you. So let me discuss with my internist what is his opinion on this issue, or what are the recent advances. But nowadays, that is the way forward. Whenever there is a cytokine crisis or anything, then plasmapheresis role comes, as in case of COVID also. In the end, these stages, these things start coming. So the time is finishing now. I hope this helped you. So next time somebody has to present me a case. The case could be any. So what you should do is at least 1 or 2 days who is presenting should tell me on WhatsApp, because if there are more than one persons who are planning to do, then I am going to choose depending upon which case is more important from examination point of view, and which is more common?
So right hypochondric mass. I have
If
a case of
somebody-
right hypochondric mass.
If anybody can present the case, it's okay with me. मगर आप अगले वेडनेसडे तक मुझे आप मैसेज जरूर कर दीजिएगा, वेडनेसडे थर्सडे को मैसेज करिएगा आप सभी लोग. So I hope
Sure,
you
sir.
have
We will message
gained
you.
something in this session. Is it
So
helpful?
it's very helpful. Thank you so much, sir. It's really helpful, of course. Yes.
Yes, that's true. Thank you, sir.
Okay.
Thank you so much.
Khuda Hafiz. Bye bye.
Thank you,
Hafiz,
sir.
sir.
Thank
Allah
you
Hafiz.
so much, sir.